Hi everyone, we'll just give it maybe 2 minutes and then we can start. Just for some people to trickle in the meantime. All right, everyone. I think we'll give it a start, and then whoever else wants to join us, they can just trickle in at the end. So yeah, welcome everyone. This is our last finals series session of the year. It's been a road. I'm Millie. I've probably met some of you before, some of those sessions, and I've got Sophia as well with me. And we'll both be doing the session today. We'll cover sexual health topics, really kind of leaning into what we covered last week. Options I need you. Oh, sorry, that's just a bit of feedback from my side. So yeah, we'll cover a lot of the STDs that you might see. We'll cover a bit of HIV, hepatitis, which obviously are STDs as well on the same side, a bit of contraception. And yeah, that's really it. So I think let's get started. We'll have the same format. We'll have some questions that you guys can answer. We'll put them in a poll. And then we'll go over the answer options and explain a bit on the topic as well. So our first question is this one. I'm just going to let you guys read it, and then we'll pop the poll in a second up, and then we'll see. I've got a 50-50 split between A and B, which is good. Just remember to, yeah, just wait to see if anyone else wants to shift it either way to see. Oh, third option. Okay, fine. Yeah, sorry, this is really just like testing your guidelines on it. Something worth knowing, to be honest. Okay. All right, perfect. It's got a lot of options with a split between A, B, and C. The majority of you guys are saying A, which is absolutely right. The main point in this question, why the people who didn't pick B are not correct, is this woman is pregnant. So we can't give any doxycycline in a pregnant woman. So that's why azithromycin is first line in someone who's pregnant, whereas doxycycline is first line for everyone else. So let's talk a little about the chlamydia. So chlamydia is an STD. It's the most common STD that we can find in the UK. It is largely asymptomatic, which is one of the problems. It's easily treated as well. The symptoms usually from men range into, or men, we should say, someone who's got a urethra, they have dysuria and urethral discharge that's usually white. They can also have epididymitis. So think of kind of your UTI symptoms with maybe a bit of discharge on top of that. For vaginal, again, so it could be dysuria, same as with an UTI. You might have some PV discharge, similar to the urethral discharge, PV bleeding, or pelvic inflammatory disease, so pain. Can be another late complication as well. Rectal gonorrhea, so important to know that rectal chlamydia, is also a thing. Vast majority is going to be asymptomatic, or you're going to think of sort of proctitis, so pain, bleeding, and discharge from the rectum as well. Oral chlamydia, again, it's usually asymptomatic. Generally, oral STIs, you're not going to have any symptoms of it. So if someone's got a sore throat, that's not really an indication to do an STI test. But yeah, that's how it would present. In terms of testing, in women, we tend to do vulvovaginal swab first. So it's either self-testing, or we can do that as well. If you're thinking PID, you can do an endocervical swab as well. For men, we'll just do a first void urine. Remember that the window period is 2 weeks' time. So in the first 2 weeks, if you do a chlamydia NAT test, and a negative might be false just because it's in the initial period. After 2 weeks, if it's a negative, that's reliable. What you can also do in an asexual health practice, you can do a gram slide of the discharge itself. Generally, that's more for the men that we do. And this will show you non-gonococcal urethritis. So you're going to see loads of pus cells, which you can see here. They look like paw prints, but you're not going to be able to see any bacteria. And equally, that's very suggestive of chlamydia. It's obviously not a diagnostic test, but it's very suggestive, which means that usually we would treat it in a sexual health clinic as well. Treatment, just quickly. So doxy, 100 milligrams BD for 7 days is generally first line, and second line would be, as some of you rightly said, something like erythro, amoxicillin as well. If someone is pregnant, we obviously can't give doxy, so hence the azithromycin will be first line. Counselling, so the partner notification for men is 4 weeks prior to the onset of symptoms. For women and asymptomatic men, it's actually 6 months, so it's a very long time. They need to abstain from sex for 7 days, so until they complete the doxy, essentially. And because chlamydia is usually very sensitive to the doxycycline, you don't need a test of cure if you use the first-line treatment. In pregnant women, or if you use second-line treatment, you might want to consider a test of cure. Just remember that chlamydia test, so NAT testing, also picks up the dead DNA from bugs. So your test is going to remain positive for up to 6 weeks. So if someone does want to test for reinsurance, make sure you tell them only to do it after 6 weeks' time, otherwise it's going to distress them further. And I think that's it. Let's move on to question 2. All right, getting some people for B, gonorrhea. Let's see if we can get a few more responses, maybe 10 seconds. But yeah, those of you who wrote it, you're absolutely right. It is gonorrhea, and I'll explain in a second why gonorrhea over chlamydia, and over the other ones, to be honest. So yeah, so gonorrhea, the other really common UTI STD that you need to know. Symptoms overall are very similar to chlamydia. So you'll have your urinary symptoms. So you have your dysuria and discharge either via the vagina or via the urethra, or if you're thinking of a rectal infection, you could have rectal discharge as well. The main difference, to be honest, in terms of differentiating them clinically, will be the discharge. So in chlamydia, not everyone has discharge, and the discharge generally is sort of a white area, whereas in gonorrhea, you'll have a lot of discharge, and patients will often tell you they've got a lot of discharge. It's often yellow or green coloured as well. So clinically, you can differentiate them very, very quickly. If you work in a sexual health practice, that's a very quick thing that you can do. With gonorrhea, just be mindful that it can also disseminate. So you can have, it can kind of migrate to your septic joint. So that's a common one that often people will talk about, but it can actually infect a lot of organs. You can have gonorrhea in the eyes. You can have, it can affect any of your organs. So always just bear that in mind if someone comes in with some weird organ infection on top of probably the gonorrhea symptoms that they'll have as well. Now, testing, again, is very similar to chlamydia. You do a NAT testing, vulvovaginal swab for women or urine for men. Window period, again, is around 2 weeks' time. If you do a gram stain slide, this is what it looks like. So we can see your paw prints, the big cells, that's your pus cells. But on top of that, you can see there's little tiny dots as well. Those are the bacteria. So you will see gram-negative intracellular diplococci. Of course, gram-negative intracellular diplococci are not overly specific to gonorrhea, but in a setting of sexual health setting, it is highly suggestive of gonorrhea. So generally what is done is you can advise someone that they can be treated based on the result of that, and then you'll still send off the urine or the vaginal swab or whatever, and you still give them the first-line treatment for it. So that's, and it's definitely recommended as well because it's a really good treatment that you can give and it will help the patient very quickly as opposed to waiting for a NAT screen to come back, which will take a few days. So definitely recommend that. In terms of treatment, so with gonorrhea, the first important step is that you want to take a culture from the infection site or suspected infection sites as well. That is because there is an increasing amount of gonorrhea resistance. So there's no harm in attempting to treat first, but you will definitely want to get a culture before you give antibiotics, like you would do in other infections as well. The first-line treatment would be ceftriaxone. You give an IM dose stat mixed with a bit of lidocaine. Alternatively, you can do ciprofloxacin, and I know in fact in some areas potentially ciprofloxacin is actually Lyme, but that's genuinely only if you know the sensitivities. That's by NICE guidelines. If someone's got an allergy, you can do oral cefixime, stat, and azithromycin. That's a second line. Similarly, you need to tell their partners, or they need to tell their partners. You need to talk to them about safe sex as well. And same as with chlamydia, they need to abstain from sex for 7 days, and they can have a test of cure after 2 weeks and onwards. And that's generally recommended for gonorrhea as well. So that's how we would do that. In terms of the question, that question two, so the main thing putting towards gonorrhea in this case, which the majority of you got right, was the fact that it was the discharge, essentially. Chlamydia, that kind of differentiated from chlamydia. Again, urethritis is non-specific. It's not an STI. This patient had a lot of risk factors for an STD. And that kind of just put it a little bit towards it. Syphilis presents a bit different, and we're going to cover that in a little bit. So that's that for gonorrhea. I'll move on to question 3. Alright, I've got a bit of split. I'll give it a little, maybe 10 more seconds to see if anyone else wants to say something else or balance it out. Probably important to point out that this is a STI targeted session, so we're going to focus on STIs in this session. Right, fab. I'm just going to reveal the answer. So the correct answer is actually HIV seroconversion illness. And I appreciate that it's quite vague, but I tried to put loads of clues in the question to kind of see it. So I've got a 2-week history of someone with fever, sore throat, and this macular papular rash all over the body. He's recently returned from Southeast Asia, where he was traveling. Didn't really give you a specific sexual history. However, HIV is more common even in people who travel, because it is more common in Southeast Asia, or more undiagnosed, we shall say. Malaise, myalgia, mouth ulcers are all common symptoms of seroconversion in HIV, the same as cervical lymphadenopathy. I well appreciate that this could be sort of going into dengue fever or secondary syphilis. Maybe secondary syphilis less, based on the symptoms are not really fitting with syphilis, which we'll talk about in a second. So yeah, let's talk a bit about HIV and also just when to suspect it, really, because as you know, the symptoms are quite unspecific. However, it's really important that we pick it up if it presents with a seroconversion illness like this. So HIV, I think we all know. So it's a virus that is transmitted via bodily fluids. So often blood can be transmitted to semen, vaginal fluid, even rectal fluid and breast milk as well. Most common transmission are during sex. They can also be from mother to child, vertical transmission, or blood exposure of any way. So things like needle stick transfusions, intravenous drug use and sharing needles, things like that. On the right side, you've got, it's quite an old table, but it still pretty much stands on what the risk actually is for getting infected with HIV if someone is HIV positive. You can see that the clear, it's just based on the anatomy, to be honest, is that receptive anal intercourse carries the biggest risk in sort of getting HIV from someone if your partner is HIV positive. For vaginal intercourse, the risk is actually very, very small. Which is also why there's sort of we don't worry about it as much in people, and why there's less of a strategy to push against it. Really important, needle stick, probably the one really important for most of you guys as well. That it's a needle stick. It's actually very low as well. But of course, if your patient is HIV positive, you don't want to risk it, so you do need to report those needle stick injuries as well. And then blood transfusion, very high risk because it's a lot of blood. So yeah, with HIV, we're focusing mainly on sort of the early symptoms here. So usually takes around 2 to 4 weeks on average. Not everyone is symptomatic of it, as around 60 to 80% of people, but the figures I found were actually quoted quite differently. People generally describe it as just a very, very bad flu or something like that. So, but it is significantly more severe than any cold or flu or that someone would have had. So if someone says they've been feeling unwell, but if they compare it to a recent flu they've had, it's a lot worse. That should be a red flag, because it is quite severe. This is a picture of the rash, what it would look like on Caucasian skin. Again, not present at all the time and much more difficult to appreciate on darker skin as well. The other symptoms are very unspecific, so things like sore throat, malaise, myalgia, diarrhea, mouth ulcers, they're very unspecific, to be honest. So have quite a low threshold and have quite a low threshold for suspecting it as well, and just to check it really. With HIV, I always just say to test everyone who consents to it. generally symptomatic patients, you will present for seroconversion, you will want to test. People who take PrEP, so the pre-exposure prophylaxis, have to take it. People who have HIV contacts or sexual assault victims generally qualified for it as well. Anyone who wants it can get it done in emergency departments. It's an opt-out testing at the moment, which means that most people who come to the wards actually should have had a HIV test at some point. It's done in blood transfusions, blood donations, routine pregnancies. And then there's also certain condition indicators. So if someone presents to ED, for example, with, I think famous one is Kaposi sarcoma, very specific for someone on HIV, so you want to test for that as well. The fourth generation HIV tests have a window period of 45 days. So you can kind of see on the right side here what happens. So initially you're going to get a spike of HIV RNA, and then with time you're going to build up your HIV antibodies. So in the initial acute seroconversion phase, your RNA, so your viral load, will be particularly useful. So that's generally, you should probably add that if you're thinking about seroconversion in someone. If it's a routine test for someone who's not symptomatic, you probably just want to do your fourth generation. So that's your HIV 1 and 2 antibody, and your P24 is generally combined. Interestingly, in infants as well, that are less than 18 months, you do an RNA viral load as well first. Exactly why, I am not sure. But yeah, so... And just if someone presents to you with that, you probably want to counsel them that they should return back in 45 days to have another HIV test, just to make sure that they are that the test is truly accurate. All right. Treatment. So obviously, I'm not going to go over the whole thing. It's very complex to treat. Generally, you want to notify their partners. And they will need to be referred to a HIV clinic. They'll need a lot of counselling probably as well. The baseline checks generally the health of them, as well as for HIV, you'll need to see your resistance, your viral load, and your CD4 count, and all these lovely things that they will know about. Generally, they're started on ART immediately, so it's changed. It used to be once the CD4 count drops below, but now it's immediately because we know that's really protective. The drugs vary. It's usually a combination PrEP, which is just 1 tablet a day. Initially, they have some side effects, but it's usually tolerated quite well, and they will be followed up in HIV quite regularly, so every few months initially, and then I think it's up to every 6 months or yearly, depending on if they're stable. And then they get some general lifestyle advice as well. And yeah, generally the prognosis, if someone is diagnosed early with HIV, is actually really good nowadays days. The life prognosis or life expectancy is the same if someone is diagnosed and is compliant with the treatment. So yeah, made some amazing progress with that. All right, let's move on to question 4. I think the key word in this one is active syphilis infection. But I know that syphilis serology is insanely complicated, so we'll go over it afterwards. All right, fab. Good spread. So the correct answer on this one is actually B. So we want to order a non-troponin test. Lists of those there's a few. VDRL is one common one, but we'll go over why that is the case. So just to recap from this question, so we've done a positive troponin-specific test in this lady, which is significant for syphilis. The issue with syphilis testing is that some of the tests stay positive after someone's been treated. So in order to properly interpret a syphilis result, we usually will need both in order to think about that. And also maybe a history would be great in this case to see if this patient has ever had syphilis and if they've never been treated, and after the treatment, what the sort of, if they had the test of cure was good or negative afterwards. So that's the main thing. So as a result, or we go for syphilology. I've got a nice diagram up. So with syphilis, I've got loads of pictures. Syphilis, again, it used to be really, really common. It's become less common these days, but we can still see it quite a lot. You've got your primary syphilis, which is, again, applied a range 90 to 90 days. You generally got your chancre, so you've got two different pictures here. And then you can also have local non-tender lymphadenopathy after that. It then goes away. People often don't take treatment, or sometimes don't take treatment, and then things come back up again. So this is sort of ranging from 6 weeks to 6 months afterwards. You get this rash. You can get fevers, lymphadenopathy. You can get your snail tract ulcers as well, and then you can get condylolamata lata, which is the picture on the right there. So you get this kind of moist lesions as well. That generally goes away as well. And then you get tertiary syphilis if you're unlucky and if you've not been treated. So that's sort of ranging from a few months to 10, 20 years plus. It's really quite broad. It's difficult to kind of summarize it. Largely speaking, syphilis can either present with gummas, which you can see in the pictures here. So this is lesions. It can be neurological, so things like general paralysis or tabus salis, or I think something of the insane. There's loads of neurosyphilis complications, essentially. It can also affect your cardiovascular disease, cardiovascular system, sorry. But we're not going to dwell too much into it because it's really quite a separate topic at all. But yeah, so we're definitely in the first phase here now. Now, when it comes to syphilis serology, you need to differentiate between your non-troponominal and your troponominal tests. So in this case, we know that the second one, the specific one, was actually positive. So in the non-troponominal, the ones that usually tend to go first. But they're also non-specific. So if someone is pregnant, for example, or has lupus, those will also go up. So those being positive by themselves is also not specific. So you'll need your troponin tests to be positive. The troponin ones are more expensive to run as well. So that's generally why if you do a routine test for someone who's asymptomatic, you'll do your non-specific ones first. And then if that is positive, you then want to differentiate what is going on. Generally, the non-specific, the specific ones are going to remain positive after you finish treatment, which is why it's important that if you're worried about an infection, about an active infection, you will want to do the non-specific ones as well. So I think there is a mistake in this graph actually. Now that I'm just looking at it, I think this one was meant to be positive as well. But yeah. Sorry about that. But yeah, just important to remember your troponin tests are going to stay positive after treatment, but your non-troponin tests are going to return back to negative. So that's the way to test for someone if someone's had syphilis in the past, basically, if that makes sense. Yeah, sorry for the confusion on this table. Need to really adjust this. And yeah, I think that's it. All right, question 5. Sorry, it's another serology question. I apologize. But there's something that just unfortunately you need to get your mind to. All right, fantastic. So the majority of you got it right. Well done. So it is indeed B. And we'll talk. I think I've got a good slide on the test later to summarize it, hopefully. But essentially, just to so your HB surface antigen is positive, your IgM, the immediate one, is negative, and your IgG is positive. So let's all remember that, and then we'll go back to our table. So quickly run through all the hepatitis C's because they can be transmitted via sex. So hepatitis B, main concern. So hepatitis B, it's spread via blood or other fluids, similar to other things. Incubation period is quite long, so it's around 6 to 20 weeks. Generally presents with things like fever, jaundice as well, and then if you do blood tests, you have a deranged LFT. Managed with antivirals or this thing that I cannot pronounce and not going to attempt as well. But yeah, treated usually generally very well. Complications would be things like chronic hepatitis, liver failure, hepatocellular carcinoma, and amongst other things as well. There is a vaccine available for this one, which is given in babies and high-risk groups as well. Now, to go to the serology, the bit that's confusing. So, first look at your surface antigen. So your surface antigen, HBsAg, indicates a current infection if it's positive, okay? So if that one is positive, you know that they're infected. Now your only question is going to be if it's a chronic or acute infection, okay? So if you look at your IgM, that's the immediate one. So that one's going to raise first. So that one's generally raised in acute infection. That one then generally slows down after a few weeks to months, I believe. And then after, I think the cutoff is 6 months. If your IgG is going to be positive by then, but if it persists and your IgM is negative, that suggests a chronic infection of hepatitis B. And that's really that's how easy in a way that test is targeted. Your anti-HBs, so that's your surface antigen, is immunity by vaccination or exposure. But that one's going to be chronic negative in chronic infection as well, sorry. And then you've got your HBeAg, which I very rarely see, to be honest. It's a marker of replication and infectivity. So that one you can do to monitor someone. But I generally don't really see it in questions either, or even in patients. It's very rarely seen. So as long as you look at the surface antigen together with the infection marker, with the IgMs and IgGs, that's a really quick way of kind of screening it into seeing what's going on. All right, fab. So I think I've got some quick slides on all the other hepatitis as well. So we've got C and D, very similar. C is the risk is fairly low via intercourse. Presents with liver picture, jaundice, LFTs, things like that. The most common complication of that one is chronic hepatitis C. And then the main thing with this one to note is that there's no vaccine available, unfortunately. However, treatment options are getting out there, so we're getting somewhere. Hepatitis D, there's no vaccine available for this one. However, you need to be infected with hepatitis B in order to get infected with hepatitis D. Hence, if you get vaccinated for hepatitis B, it effectively protects you against hepatitis D as well. And also is treated very, very rapidly with interferon as well. And then we've got hepatitis A and E, which are generally by a fecal oral spread, but due to oral sex, that still can happen in sort of your sexual health setting, especially in your men who have sex with men. Hepatitis E generally is very self-limiting, and its majority of people is harmless. However, we do give a hepatitis A vaccine, in people who we think are high-risk groups. So that would be either people who are at high risk of getting complications, so someone who's got chronic liver disease, or someone who's at high risk of getting it, such as men who have sex with men. They are eligible for the hepatitis A vaccine. Hepatitis E, this one, again, it's a fecal oral spread. It's very similar in terms of presentation to hepatitis A. This one is more severe. So in pregnant women specifically, there's quite a high mortality rate associated with that. And there is a vaccine in development as well. However, the last time, or when I was making slides at least, I don't know what happened to that. So that's your hepatitis is hopefully quickly summarized. So I'm just rushing a bit through it because it's not the most exciting. But yeah, hope that makes sense. And we'll go to question 6.
Thank you, Millie. We'll give it a couple more seconds. Okay, one more response. We can do it. Okie dokes. So this question is asking whether or not you know your STIs. So the answer for this question is A, genital herpes. So we'll go through why it's not the other ones. So this patient has presented with really painful ulcers, and then there are multiple of them as well. So it looks like it's in a cluster. She's not got any lymphadenopathy, and she feels a bit under the weather as well. So all of those are pointing towards genital herpes. Primary syphilis, as Millie talked about before, and you've got the 3 stages. So the first stage, you've got the sort of painless single ulcer, and then it can progress on to stage 2 and stage 3 later. So she's got pain, we can rule out B. C, chancroid. So it's quite similar to herpes. However, chancroid is caused by a bacteria, whereas herpes is a virus. And as you expect with any sort of bacteria, they tend to produce a lot of pus. They tend to look really gunky. And the ulcers tend to be quite a bit bigger and a bit deeper. So in the question stem here, we see that she's got small and shallow ulcers, again pointing to herpes. So we can rule out chancroid. Lymphogranuloma venereum. So this is caused by chlamydia, I believe. And it tends to be more common in men who have sex with men. The first stage, again, it's another 3 stages. The first stage is a painless ulcer as well. And then the second stage can be sort of bilateral or unilateral lymphadenopathy. And then you can get sort of strictures and fistulae after that. So doesn't fit the picture for lymphogranuloma. And E, Behçet's disease. I tend to think of it more as a rheumatological condition. So they've got widespread inflammation that affects their bones, they get uveitis, their eyes, they get oral ulcers, they can get genital ulcers. And so she's not really complained of any other sorts of systemic inflammation. So you can rule Behçet's out as well. So a bit about genital herpes in that case. So patients can present with a sort of flu-like symptom at the very beginning, and they can present sort of tingling and itching, sensation down below. And then over time, they can get these really small, really painful blisters that hurt even when you're not touching them. But if you wear really tight clothing, it can exacerbate the pain. So one of the management steps is sort of wearing looser clothing. They can present with dysuria or difficulty opening the bowels, again, because that irritates the ulcers. And they can also present with tender lymphadenopathy. So it's always, always very important if you've got a patient presenting with any sort of STIs to feel around the groin for any lymphadenopathy. And it tends to resolve on their own after a few days or weeks. In terms of management, so you can do a swab. And then once we've diagnosed it clinically, in most cases, we can give a 5-day course of acyclovir, so an antiviral, and these just sort of general lifestyle things as well. So saline baths, it will sting, but it will help. It's kind of similar if you get an oral ulcer as well. The first thing they'll say is try a saline wash in your mouth. The saline just sterilizes the area. You have to do it about 2 or 3 times a day. It will sting, but it will be better in the long run. So that's why analgesia is also very important. So a bit of paracetamol, and you can get some topical anesthetics as well. But patient education is first and foremost. It's very important, and in general, you should tell the patients to inform their partner because herpes is very contagious. In some sexual health clinics, they also offer a service where if the patient's not comfortable telling their partner themselves, then you can take the number of their partner, and then the clinic will phone the partner and tell them anonymously and just say, well, we're here to just inform you.
Yeah, they did that where I worked as well, so the education is very good over there.
Yeah, good. Yeah, so patient education, number 1 priority. In pregnancy, so there is a risk of herpes passing on to the baby, and it can lead to very severe complications. So we do get quite worried, especially in the 3rd trimester. But if the mother has herpes a bit earlier on, or they've had herpes before, then we can manage with sort of regular acyclovir until a certain number of weeks, and we can still offer vaginal delivery. However, in the 3rd trimester, you would still offer the acyclovir, but you would want to think about C-section, just because the baby is at a slightly higher risk of contracting the herpes. Next question. Brilliant. So we've all gone for C. So very well done. So this lady, she's 23-year-old, she's had sex 101 hours ago. And she's currently on day 21 of her 28-day cycle. So this question is asking whether or not you know how long, or the time frame in which you can use different types of emergency contraception. So levonorgestrel is only really suitable if you've had an UPSI or sex within a 72-hour period. So A and B are just ruled out, so you're left with C, D, or E. So ulipristal, it can be used within 120 hours, so it has a slightly longer time within which it can work. And in terms of hormonal contraception, so the POP contains progesterone, but it can also interact with the hormones in the ulipristal. So we generally recommend that you start the POP after 5 days, rather than immediately after using the ulipristal. A couple of things to consider as well with the ulipristal is that you have to be cautious if they're on any other medications, such as enzyme inducers, or if the patient has asthma. So she's not got any of those other medications or asthma. It's always really important to ask. Enzyme inducers are things like sulfonylureas or carbamazepine. If they're chronic alcohol drinkers, if they're on rifampicin, there's a really nice mnemonic, scrap GP, for enzyme inducers. And for enzyme inhibitors, you can use sick faces. So if you just Google that, it will come up with a nice list, a mnemonic for you to memorize. It's really, really useful for exams and for PSA as well. So emergency contraception. You've got 3 main types of emergency contraception. So you've got the copper IUD and then the 2 that we just talked about. So in general, the copper IUD is the most effective. Always look for the copper IUD first, unless there's a contraindication to using it. But a lot of women, understandably, aren't too keen to have one put in, so they'd rather just take a pill. But IUD, most effective, is just a copper bit that creates a sterile environment within the uterus and just kills all the bacteria that way, and all the sperm that way, sorry. So you can put it up to 5 days after an UPSI or 5 days after the ovulation date, and it can be kept in for 5 to 10 years. Ulipristal, as we've talked about, it's got progesterone in it, and it inhibits ovulation, and you can use it within 5 days of an UPSI, and you can use it multiple times in the same cycle, which is very handy. However, again, it does interact, and also you can't really breastfeed at the same time as using ulipristal, so you just want to delay breastfeeding for about a week. And then levonorgestrel inhibits ovulation and implantation, so it's got a dual mode of action, but it's got a shorter time frame within which you can use it. And again, it can be used multiple times. Generally advise not, if they can avoid it, try not to need to use emergency contraception. If they are needing it, say more than 2 or 3 times in the same cycle, offer them the long term if possible. The levonorgestrel, be mindful about the patient's BMI actually. So if the BMI is greater than 26 or they're a heavier weight, then they will need a larger dose of it. And there's a really nice table or a nice flow chart on the next page. It just goes through when the UPSI was and which one's the most appropriate. So there's that. And the slides will be available after the session to download. So next question. One more response. We can do it. There we go. So, answer to this one. Most of us got it right, so it's B. So, range of pelvic ultrasound. So, losing an IUD is actually everyone's worst nightmare. You really don't want it. Well, actually, no, it's not the worst nightmare. There are worse things that can happen if you leave the IUD in too long. So, we really need to know where this IUD is. Because obviously there's a risk of perforation, there's a risk of infection, and
just not protection, to be honest. That's, I think, one thing as well. That if the idea is gone. Sorry.
Yeah. So yeah, we want to know where it is, and the quickest way to do that is through an ultrasound scan. So reassuring her and checking for threads, it's too long. Inserting a new one immediately, you don't know if the current one is still in there, and it's not really good practice to double up. Advising barrier contraception review again, 3 months, no way. And then abdo x-ray, you're exposing her to unnecessary radiation when you can just use a pelvic ultrasound, so that's the most ideal one here. So a bit about IUD and IUS. So the IUD, it's a piece of copper. Both of them are like T-shape, and they're very, very small. And the IUD, it's purely copper, and again, it just creates a sterile environment to kill off the sperm. And it can last for about 5 to 10 years, and it's effective immediately. But there are a few side effects, which is why some people don't really like it that much. It can make your periods a bit heavier and a bit longer than usual. So if someone already has heavy and painful periods, to avoid trying to give them an IUD. And again, we talked about the complications. So perforation, very rare, but important to counsel the patient on. Infection, risk of expulsion. So expulsion is just where it just comes out on its own. And a chance of ectopic pregnancies as well. For the IUS, so it contains the hormone, the same hormone as the levonorgestrel, to prevent the proliferation and prevent cervical mucus thickening as well. It lasts for about 3.5 to 8 years. In general, though, it lasts less time than an IUD. And it takes a bit of time to become fully effective, so about 7 days, because of the hormones in it. And some side effects include irregular bleeding, and it really depends, really, because some people might get some spotting, some people might get no periods at all. So it just really depends.
Depends on the type as well. So there's 3 different strengths, essentially, which contain a different amount of hormones in it. And the more hormone you've got in it, so the highest one is the Mirena, which stays in for 8 years. And with that one, most people actually have amenorrhea, whereas with the lighter ones, the smaller ones, people will probably still get periods. But it's individual, as Sophia said. We don't really know, and we're very bad at predicting it as well.
Yeah. So just cancel, as long as you cancel all your bases, you should be grand. So question 9, a bit of a tricky one. I'm only asking you this.
Yeah, I remember this patient. There's this patient. I spent a lot of time on this patient.
Why?
it was during contraception clinic, where you really don't have that much time anyway, and I just been going back and forth between trying to figure out what to do with this one patient, because none of the options were really ideal, and I simplified it a little bit because it was actually a lot more complex in the end, and we ended up going off license for this patient. But it was a bit of a nightmare. But the patient was very understanding. She was like, "That's okay."
Yeah, sexual health patients are in general like the nicest patients.
100%. Yeah.
But yeah, it just goes to show that everything is sort of individualized. No hard and fast rule.
Yes, and also just risk as well, because essentially, ultimately, with this case, it came down to a risk of pregnancy. and risk of, if you don't provide contraception, what's the risk of further pregnancy, with benefiting it with the current risk and all sorts of things. So, yeah.
Okay, one more. You can do it. One more. It is a tricky one, though, I do admit. Can we? 3 seconds? 2 seconds? 1 second? Okay, we'll leave it there. So it is a bit of a tricky one. The answer here is C. So book another appointment for 3 weeks. Advise to abstain from sex. So as Millie said, it's a bit of a balance of risk and understanding that a depot injection is in fact not quite it has its schedule and it's not a form of emergency contraception. So option A, so administer today, no further action required. So the depot injection, it's generally given after 12 to 13 weeks and it's ineffective after the 14th week. So if you leave it for too long, then the risk of pregnancy is a lot higher. And she's had unprotected sex in her 14th week, which means that she's not covered during that. So doing no further action, there is a chance that she's pregnant, and if you give the injection as well, that poses a risk to her and to her baby potentially. So option A is not it. Option B, so book another appointment for 3 weeks' time and offer bridging contraception with a POP. So again, it's risk. The main thing here is that she takes lamotrigine, and the lamotrigine is kind of affect like the enzymes, and all of these anti-epileptic medications have a lot of interactions, and especially with hormonal contraception. So giving a POP with lamotrigine would probably need to seek some senior advice before doing that. But if you're on your own, best to avoid doing that. And if you're just kind of leaving her with that contraception, that could again pose a risk of reducing the efficacy of her lamotrigine in the meantime. So option C is the best one here. So abstaining from sex if she can is ideal. You could always give barrier contraception in the meantime as well. That's the best sure way to say, okay, well, there is a risk you could be pregnant. We could always offer a pregnancy test as well in due course, and then advise her to abstain from sex before her next injection. And then option D, depot isn't a form of emergency contraception on its own, and it has its own schedule, so it's not appropriate to give it today. And again, option E, the depot injection has its schedule. So a bit of a tricky one. I'm not sure if Millie can provide more insights.
I mean, it was a very tricky scenario. Essentially, she's had an OPC, as Sophia explained. She's had an OPC when in the 14th week, which was unprotected, which then means that she can't qualify for the depot today. Even if we do a urine pregnancy test, it's very unlikely going to be positive if she were to be pregnant, because she would only be pregnant a week, really. So that's not going to rule out anything for us. So giving the depot is genuinely off license, and we can't give it. And then in terms of, so the best course of action if she still wants to have the depot would be to do it in 3 weeks' time. And now just a question of bridging. Obviously, if this patient wasn't going to have sex, that would be the earlier scenario. Usually, unfortunately, we don't trust patients with that. So you want to be able to offer them a bridging method, which generally would be the POP, because it's effective within 48 hours. But it interacts with lamotrigine, so again, it's difficult. In this patient, we actually considered two options. So we considered the bridging with the POP despite. So that would be just on advice. Or we considered, which we ended up going for by my consultant, which was we actually administered the depot on that day, because my consultant felt that the risk of further pregnancies, if we don't do anything, if we opt to use option C, then actually she will get pregnant very likely in the next few weeks. However, that was with the counselling that basically if this patient were to be pregnant or have to become pregnant by this past sex, she would have to terminate the pregnancy because it would not be viable while being on the depot. So that's that was the downside what happened with this case in the end. But yeah, very tricky. Indeed. I'll just give you the slides for the depot as well. There you go.
Thank you. But we only give you hard questions because you're doing so well. So depot injection, medroxyprogesterone acetate. So again, it's got a dual mode of action. It inhibits the ovulation and it thickens the cervical mucus. And it's given every 12 to 13 weeks. So generally every 3 months. And it's got its own side effects as well. The key one being the increased risk of osteoporosis, which is what they like to ask in MCQs. But you can also get irregular bleeding and weight gain and delayed return to fertility as well because of that. It works over the 3 months. And these are more common side effects that you have to cancel on. It's contraindicated if you've got a history of breast cancer, and just be really, really cautious if they've got a family history of breast cancer as well. And if they already have osteoporosis or a high BMI, again, you want to be very cautious about giving the depot. Be better to offer some of the other options like the IUD or IUS in these patients. And then our final question. Couple more seconds. Okay, so it's either you know it or you don't know it for this question. So the answer is 5 weeks postpartum and breastfeeding. So again, you know or you don't know it. Option A, so COCP is actually protective against ovarian cancer, very slightly, but it does increase your risk of breast cancer and cervical cancer. And the way I think of it is I look at the 2 C's in COCP, so you've got 2 breasts, so 2 C's, and the C is for cervical rather than ovarian. But yeah, you'll figure out your own way of memorizing it. Blood pressure, there's not really sort of any contraindication to that. Mother had a PE, so the COCP can increase your risk of having a PE in DVTs. And especially if under the age of 45. But this patient has a first degree relative who had a PE at the age of over 45, so it's not quite meeting the criteria. Option D, history of migraine with aura. So it is a contraindication as well, but it's not as strong of an indication. And you can look at the UK MEC UKMEC, UKMEC criteria to help sort of guide which of these contraindications are stronger and which ones are a bit weaker. So a history of migraine that was 5 years ago is a UKMEC 3. If it's 4 years ago, current, it's UKMEC 4. And then 5 weeks postpartum breastfeeding, that's a UKMEC 4. So that's the highest contraindication. Up until 6 weeks postpartum. So the answer here would be E. So a little bit about the COCP. So it contains both estrogen and progesterone, and overall just works to inhibit ovulation. The traditional way of taking it is 21 days of taking the pill and having a pill break. But people are seeming to move more towards a continuous taking the pill. Some people call it like the 21st century version of taking the pill. It doesn't have as many sort of side effects of like the headache and the breast tenderness, which you can get with the traditional pill taking routine, but it doesn't give you that period to have your period. So it can slightly increase your risk of sort of building up the tissue in your uterus and increasing your risk of cancers very slightly. But I think the evidence around it is a little bit wishy-washy, and so...
Yeah, it is. What is generally done from practice is that you can take it up, like recommended is that you take it up to 3 months and then you have a pill break for 7 days. So people are generally advised to have 4 periods a year, as opposed to 12. And that's how we would say it is, but the evidence agreed is not great.
Yeah, I mean, minimum 4 periods is a lot nicer than 12 periods a year. So yeah, take that if you can. But that should be reassuring for patients, especially if they struggle to follow the routine every month. They might just forget when they can and when they can't take it. So advantages of the COCP. So you can almost have control over when your periods are, and your periods tend to be a bit less painful. As you talked about, there's a reduced risk of ovarian, endometrial, and colorectal cancers. It's a very small reduced risk, however, and they may benefit in other sort of situations, but it does come with its side effects. So they have an increased risk of getting VTEs, stroke, and as we talked about, increased risk of breast and cervical cancer as well. So I'd probably say if someone has a first-degree relative who's had breast cancer or they've had breast cancer themselves, just try to avoid it at all costs. And that's our final slide is just a general table talking about the different UKMECs and when you can and can't give the different types of contraception. So as we said, UKMEC for COCP, migraine with aura, VTE, breastfeeding for less than 6 weeks, or the more than 35 years old and they've been smoking for 15 years. That's pretty much it. So, and huge thank you for Millie as well, who sort of organised all the slides for today. So this is our last finals session, I believe, but we do have a very exciting upcoming FY1 series as well, which Millie can tell you a bit more about.
Sure, yeah. We'll do, so we're doing an FY1 series in July, so it's around 3 weeks' time. It'll be also on a Thursday evening. There'll be two consecutive Thursdays, 7 to 8, where we'll cover a very brief pit stop talk on how to prepare for F1, what to do so that you're not alone on your first on-call out of hours. And yeah, we're still confirming the platform that we're going to host it on, because there's some changes to Metal, which we're currently using. But but we're uploading it currently, so we're uploading the dates and everything on our Instagram as well. So we'll make sure to stay on there to keep informed, and we'll probably post something on Medal as well, just to make sure that everyone who wants to attend it can attend it. And what else? Provide feedback if you can, please. We really appreciate it. I think that's pretty much it.
And the research survey, if you haven't had the chance to do it
yet.
Yes.
Yeah, that one as well. If I know a lot of you have stayed with us for quite some time, so you've probably heard about this survey for a long time. But yes, if you can sort it out, that'd be great. We'll just stick around for maybe 2 more minutes. Also, if you've had any questions, anything that was unclear, the slides will be available and the recording will be available on the platform afterwards as well. So if you want to go over something again, please do. Hope it was good.
Thank you for joining.
Yeah, thanks.
Keeping with us despite the nice weather.
Oh yeah, it's very warm.
Yeah, it's gorgeous.
I heard some seagulls in your background.
In my background?
I thought I did, yeah.
Well, it could have been me.
Yeah. But yeah, no, it's very warm.